CLI is when a person's lower extremity is at risk for limb loss, and that can be either due to rest pain or superficial or deep tissue problems, and those problems are due to lack of circulation, preventing the wound from healing. When a patient comes into my office, usually it's not in the hospital. Usually it is an outpatient evaluation. But one thing that I think is imperative, especially being on a limb salvage team, is that the patient gets in urgently. Within a 72-hour period of contacting the office or at least the physician. So I think that's the first thing that I do in my evaluation. Make sure they get in early on. The next thing I will do is really discuss what the other risk factors that the patient has, because I think that really entails how difficult the case is going to be, what their outcomes are going to be, whether their body mass index is really low or really high. They have comorbidities, diabetes, high blood pressure, smoking, their age. So that first part of that evaluation is really getting to know what they have going on. And even the aspects of, do they live alone, do they live independently? All those things I think will predict what are predictors of what their outcomes are going to be. So I think all those things are important to get. Certainly my next evaluation, first thing I do when I'm evaluating the patient, I put their leg up that's affected and put it up on my knee, and while I'm talking to the patient. And because I get a chance to let it sit there for a few minutes and see if they do get pallor or if it gets cooler or anything else that would suggest that there is occlusive disease. And it's amazing how many times that when the patient sees that, it's like all of a sudden they go, oh yeah, gosh, my foot's white now. And they get it. They understand that there's totally occlusive disease. And I think part of that process is educating the patient, and they see really what happens, and then they understand why they're having pain at rest, mostly at nighttime when they elevate their legs. And then the third thing that I do is certainly get a Doppler or some baseline study. I really don't need after you've evaluated the patient, seen the patient, examined the foot, you really don't need to have a non-invasive test to really evaluate if you're going to bring that patient to the lab. You already know whether they need revascularization. So I'll get some form of non-invasive testing, not just to diagnose it, but really to have a baseline so I know where they started pre-intervention and to see where they go post-intervention immediately. I think that there's a dual or multiple therapies for CLI. Certainly intervention is one of them, but we can't forget the medical aspects of a patient, and certainly there's medical evaluations that go into it and medical therapy that will be there. First and foremost, if they smoke, they have to have smoking cessation counseling and really work on them quitting. Second, certain antiplatelet therapy I think is very important for these patients, and maintaining that in them. Statin therapy is important for them because we often talk about what the mortality is with CLI patients, and it really is cardiovascular death and disease. And so it's not just that leg that we're trying to save, but trying to save that life, we have to treat them medically. So statin therapy is imperative in all these patients. If they can't be on a statin for whatever, that's the only reason they should not be on a statin, is if they can't be on it. Outside of that, really, I think just other factors, blood pressure control, diabetes control, all those things go into limb salvage and wound healing. So we can't forget about the medical aspects that on treating these patients. Sometimes when you're in an intervention, it is very difficult to define what is good enough and when do you stop. Certainly try to get with the angiosome principles and try to certainly get the proper blood vessel to the proper foot and anatomically with the angiosome theory. But I think more importantly, I think tibial branches, whether it be posterior tibial branch or tibular, and really completing that the tibial loop that connects the plantar vessels to the pedal vessels, pedal loop. I think making that sure that the integrity of that is there. I think that when you have limb salvage, usually it's going to be digital, or it's going to be at the plantar aspects of the foot, whether it's the heel or what have you. And you really need to have that tibial loop patent, because I think that way it covers really the whole entire foot, and it's what really gets out to the digits as well too. So that's, that's almost one thing I try to make sure I leave the lab with that open. And if I do, I know I've achieved my goal. If I can't get that open for whatever reason, then certainly trying to get at least a patent vessel to the foot of some sort. But I truly believe that pedal arch is one of the most important things to make sure that you have patent before you leave the lab. Whether or not amputation rises or falls with CLI, I think is a good question, because the problem is that the incidence of CLI is, I think, going to go up just because of the risk factors of it. The diabetics we have the diabetics, we have advanced age. All those things lead to patients who can develop CLI. So I think the volume is going to go up. I think the percentage of amputations will eventually go down. We were looking at a slide, from a Medicare database from 2003 to 2006 earlier, and how it showed that over half the patients don't get an angiogram, or at least an evaluation, prior to having an amputation. But and that seems to be a standard slide that's out there that we have, but we don't have 2014, 2015 slides. And my gut tells me that, and I know amputations rates have gone down because of this, and limb salvage rates have gone up. But it'd be nice to know those numbers. So I do think ultimately the percentage will go down, even though the volume will go up. But I think with all the education and awareness that's out there, just like AMP, the meeting, it really has impacted a lot of people in what they do. And I talked to a lot of people after the meeting who have attended it. And one of the surgeons I was having dinner with the other day had said that when he came away from AMP, and when he had come to a training program of mine, he actually ends up doing more than he thought he could ever do, and it made him push the envelope. And I think that's where we're headed. More people are doing that. We have more people really interested in treating CLI, and not just amputating the leg. So I think we're heading in the right direction. I certainly believe that, and I think our rates will eventually go down because of that.